Right. Hello. So we're going to talk a little bit about edema, then other thromboembolic disorders, as well as as well as hemodynamic disorders that affect your your vasculature. Right. So we can talk about what we call edema. We also have what we call effusion. So usually when we talk of edema, this is simply when fluids are going to build up in tissues, and there are various causes to include hepatic. They can be cardiac causes for heart failure. They can be renal causes, for example, your nephrotic syndrome, where you're generally losing protein. Right? So you can classify causes of edema into quite a number of things that I'm going to do shortly. But when you talk of an effusion, this is now fluid that is building up within body cavities. So you can think about the pleural cavity, you can think about a pleural effusion. You can have pericardial, you can have peritoneal effusions. And so these are just fluids that are building up inside your body cavities, right? And how do we get to such a scenario? You remember we talk about Starling's forces, and Starling's forces, they simply entail the the net effect that your forces, or basically the physical forces that determine the net fluid movement between the vascular compartment and the tissues. And usually we say this Starling's forces, or maybe let me create a new equation. So we would say that the net flow of the fluid would be equal to hydrostatic pressure within the blood vessel minus oncotic pressure within the blood vessel, close bracket, open bracket, O minus hydrostatic pressure within the tissue, subtract oncotic pressure within the tissue. But keep in mind that the oncotic pressure in your tissue then becomes a zero. So meaning even though it was minus and a minus going to give a positive, the end formula would simply be H1 minus N1 minus HT, right? So what then increases a net flow of fluid for us to end up with an edema? So we can have increases in your hydrostatic pressure, or you can think about things that decrease your oncotic pressure within the vascular compartment, right? And also remember how we then talk about transudate and exudate. I'm sure I've gone to town with this issue. And you know the difference is how when you have a non-inflammatory edema, which usually is non-pitting, that's a transudate, which is explained by such. Whereas when you think about exudate, this is usually an inflammatory process marked with a high protein concentration as well as a higher specific gravity, right? So think about things that increase your hydrostatic pressure, right? So you have things that impair venous return. So shortly, I'm going to tell you a difference between congestion and hyperemia. Or let me just talk about it now. Congestion is impaired venous return, which is a passive process which results in engorgement of vessels. And since it's usually venous blood, it's going to be bluish. It's going to be a dusky bluish appearance because of blood that is rich in carbon dioxide. Whereas when it's a hyperemia, you think about an active process where it's an inflammatory process marked by dilation of blood vessels, resulting in the rubor that you talk about in your inflammation as one of the four cardinal signs of inflammation, right? So when you think about increased hydrostatic pressure, you're thinking about impaired venous return. So you can think about people with deep vein thrombosis or any other impairment that stops the return of venous blood, or someone who's in heart failure, right? Then for oncotic pressure now, you don't need to increase this one for you to have edema. It actually needs to go down. So you have causes like malnutrition, where you're thinking about someone lacking protein in their diet, maybe they're kwashiorkor or severe malnutrition in the younger children. So these things can lead to a decrease on oncotic pressure. So the pool for the fluid to remain in the vascular compartment becomes less. But at the same time, you can think about certain pathologies that can lead to protein loss. For example, there are certain protein losing enteropathies in the GIT. You can also think about things like nephrotic syndrome, which you do in the renal system, where you're simply losing proteins in the body, so that the protein level eventually gets very low. And these people present with a form of generalized body edema, which we call Anesuishe, where it can be all the way from the head to the foot, right? Then you can also have hepatic problems that cause a decrease in oncotic pressure, where there's a defective mechanism in making your plasma proteins, right? Then you can think about someone with liver cirrhosis. So usually, if you remember the position of the inferior vena cava, it can be affected by liver pathologies resulting in impaired venous return. That can also help with increased venous return to the heart, right? Then other causes of edema can be things like lymphatic obstruction. This can be surgical, or even someone who's had a chemotherapy session, or maybe someone with an infection, someone with a cancer blocking your lymphatics. All those things can cause lymphatic obstruction. But more inclined to your physiology, you think about sodium. So sodium retains water. So if you have any pathologies that are retaining sodium, for example, you have a renin aldosterone producing tumor. This simply increases aldosterone, and aldosterone, the net effect is to retain sodium and secrete potassium in your renal tubes. So if you're retaining sodium, that means you're going to retain a lot of water. And when you retain a lot of water, that is going to predispose to edema, because what you do, you increase the hydrostatic pressure. Then you vasopressin, or antidiuretic hormone. So when you have syndrome of inappropriate ADH secretion, we'll cover this much when you do your endocrine pathology. But when you have SIADH, when you have excess vasopressin, which is antidiuretic, you're going to retain so much water such that you can end up with a net increase in your hydrostatic pressure as well, thereby retaining to a net outflow of water. Then also, edema can also be linked to inflammation. Remember the tumor that we associate with acute inflammation. Why? Because you're going to have an increased permeability that is affected by things like histamine. So those things increase net permeability of the tissues, resulting in a net accumulation of water within the tissue, hence your edema, right? And then you also need to understand the concept of hemostasis, and we have hemostasis. Usually we talk of primary hemostasis and secondary hemostasis in cases where there is endothelial damage. So in these cases, you're trying as much as possible not to lose a lot of blood from the vascular compartment. Say you've had a hemorrhage. Hemorrhage is simply extravasation of blood from your intravascular space, either externally or internally into any potential spaces that are there, right? So hemostasis, we now need to form clots at the sites of vascular injury for us to stop the bleeding that is going to be happening there, right? So what are the processes that happen? So when you have vascular injury, the first thing is to have a vasoconstriction. Why do we vasoconstrict? You want to vasoconstrict such that you don't have too much blood going to a site where there is an injury. And if you vasoconstrict and you have less blood going to that site, that means that you're not going to lose excess blood because you're vasoconstricted, and you're going to have less blood actually going to that injured area, right? Then we talk about a primary hemostasis, where we are simply dependent on platelets to form a platelet plug. So normally, when everything is functioning well, remember a blood vessel has a tunica intima. the tunica intima has an endothelial layer and a subendothelial layer. Within the subendothelial layer, you have collagen, right? So when there's no endothelial injury, you'd find that your platelets within the blood, they're not coming in contact with any collagen, but platelets have GP1A receptors that are responsive to collagen. So when you have vascular endothelial injury, the collagen is exposed, right? You are going to have platelets binding to the collagen, and they're going to release factors that invite more platelets to the site. And remember, platelets also have a GP1B receptor, then a GP2B3A receptor. The GP1B receptor will bind von Willebrand factor towards the endothelium for them to adhere. Then for them to aggregate, you now need the GP2B3A receptors to on one platelet and one on another platelet. Then you have fibrinogen in between to cross-link that thing. Actually becomes a little bit stable. But then again, this primary hemostatic plaque is not that strong. That's why you then need the coagulation cascade, right? And maybe just as a side note, problems with the GP1B receptor, we'll talk about Bernard-Soulier disease, where you have the big suckers, basically big platelets. And then Glanzmann thrombocythemia speaks to a problem with the GP2B3A receptor, which is for fibrinogen, right? So after having formed that, you now need the secondary hemostatic plaque. So for the secondary hemostatic plaque, you're thinking about clotting factors. So there's an intrinsic pathway and an extrinsic pathway. The intrinsic pathway and the extrinsic pathway will converge at a common pathway. So I'll try to draw this to make it simple. So I'll start with the intrinsic pathway. Okay. So you will have, so these are written in Roman numerals, but for the purposes of the video, I'm going to use numbers so it makes it easy to use the kind of pencil that I'm going to be using. So you have factor 12 that is not activated. So you activate factor 12 to activated factor 12. So remember, you need to write this in Roman numerals. So this should be like this, but I'm not going to do that, right? So you need to activate this when you've had vascular injury. Activated factor 12 will activate factor 11. So factor 11 will be activated to activated factor 11. So the A there means activated. So activated factor 11 will activate factor 9. So it's 12, 11, 9. So you activate factor 9 to activated factor 9 using factor 11 that is activated. Then you activated factor 9 plus factor 8, activated factor 8 together, they make what we call the tennis complex. These two will activate factor 10. So you activate factor 10 to activated factor 10. Activated factor 10 will combine with factor 5A, activated factor 5, to form this prothrombin complex to activate factor 2, which is your prothrombin, to activated factor 2, which is thrombin. It is this thrombin that we need to convert factor 1 to activated factor 1A. Factor 1 is fibrinogen, then activated factor 1 becomes fibrin, the one that forms the meshwork of the secondary hemostatic plaque. So this is more of hematology, but just need to get a broader view of what's really happening. In the extrinsic pathway, you simply have vascular injury, then you have tissue factor. When you have the tissue factor, this tissue factor will activate factor 7 into activated factor 7. The activated factor 7 will go, where am I on the diagram? Will go all the way here to activate factor 10. Then you go into the common pathway where they are now similar, right? So this just speaks to intrinsic and extrinsic pathways, something that you need to remember. But then again, when you have such clotting mechanisms in the body, we then have what we call thrombosis. So when you think about thrombosis now, the things are now going bad, right? So we talk about something that we call Veko's triad, right? So Veko's triad explains abnormal clotting or basically thrombosis. Right. So Veko's triad is explained by vascular endothelial injury. So let's just say vascular endothelial injury. Then it's also going to be explained by abnormal blood flow. So abnormal blood flow. But under abnormal blood flow, there is two. There's where the blood becomes sluggish and slow, that's stasis. And there's where the blood increases the movement, or that's a turbulent flow. The two can be incorporated there, right? Then you can also talk about a hypercoagulable state. So you can also have a hypercoagulable state, right? So there are various things that fall under all these. But remember, where you have a vascular endothelial injury, you're going to have more platelets coming to the site, then the whole cascade starts again. Abnormal blood flow, you're thinking about a turbulent flow that can cause vascular endothelial injury as well, as an example. Hypercoagulable states, maybe you have mutation of various clotting factors, or you have what we call lead-in effector 5 mutation. You can also think about things like antithrombin deficiency, because antithrombin is supposed to basically stop the function of thrombin to convert fibrinogen to fibrin, then stop the clotting cascade. There's also protein C and protein S, your vitamin K dependent part of the vitamin K dependent factors that are also there to stop the process. So those can also be deficient. But yeah, there are other things that can lead to a hypercoagulable state. And for the purpose of exams, I want you to remember homocystinuria, as well as certain cancers that can predispose you to that. Then there's what we call antiphospholipid syndrome. You can look up what that is, or a heparin-induced thrombocytopenia. So when you don't have so this is actually something that you give heparin as a medication, and they get a heparin-induced thrombocytopenia. Right? Then the other people who are at risk for thrombosis, these are people that are going to have cardiac problems or even nephrotic syndrome, the one that I mentioned to you. All these can present with such, right? So I also want you then to think about the fate of a thrombus. So it can there can be dissolution, there can be propagation, there can be more like recanalization to allow for a bit of flow. But when they usually propagate, we talk about what we call a pseudoembolus, where remember the pulmonary trunk that is leaving the heart, it bifurcates for one for the left lung, one for the right lung. So the embolus goes to sit right there. Then we can also talk about a paradoxical embolus. So when it's paradoxical now, it uses a defect within the wall of the heart to move to the opposite side of the heart, which is the left, hence go to the systemic circulation. Right. So this thrombi can develop anywhere within the vascular compartment, and we can see them histologically by appearance of what we call lines of Zahn. Right. So these are things that you can see. Supposed to be like this line of Zahns. There's an N between the H and the S there. Right. So you need to remember such. Right. Then, well, yeah, then you also need to be able to know about post-mortem clots, because you need to distinguish post-mortem clots from those that happen before you were still alive. And those that form when someone die are usually going to be a bit gelatinous and dark red in terms of color. So they have a dark red portion, which you call the red zone with red cells. Then they also have a chicken fat upper portion within them, right? Okay. Then, so yeah, I think that's that. Then you also need to know about fat embolism. Fat embolism is where now you have fats actually moving within within your vascular compartment, mostly going to be secondary to skeletal fractures or whatever, right? Then there's something called fat embolism syndrome. You need to know this one for exams, read more about it. This is simply where you have patients who are symptomatic, right? So they get pulmonary insufficiency, problems within the brain, problems with their thrombocytes, and they can actually succumb to it. Right? So you need to look up that fat embolism syndrome. Then you can also think about aembolism as well, which is now simply a gas bubble traveling within your system. Then there's amniotic fluid embolism. Well, thereabout, you think about maternal mortality, because this is happening to pregnant mothers. Where you think about amniotic fluid. So you also need to look up your amniotic fluid. Then we talk about infarcts. We like to talk about red infarcts. Then we also talk about white infarcts, right? So white infarcts occurs in end arterial organs where there's one arterial blood supply. So you need to remember anatomy as well. Red infarcts, they occur where you have things like maybe a dual circulation, for example, your lung, your small intestines, your liver, your basically those things. Then also maybe where you have venous occlusion, for example, when you have a testicular torsion, the veins are occluded, then you now have arterial blood still coming in as well. You get a red infarct, right? But there are also septic infarcts where you have an infected region with an infarct, right? Okay. Then you then think about shock. Right. I won't talk much about shock, but this is simply by simple definition, diminished cardiac output, right? Or you have reduced effective circulating volume within the blood vessels. So there's cardiogenic shock, which I'm sure you know, that's where there's a low cardiac output. There's inflammatory shock. There's hypovolemic shock, where there's now little blood within your system, right? And there's also a septic shock, right? Okay.